Okay, please keep eating your dinner, drinking your wine and having a nice relax there. And tonight I'm just going to give you a little bit of food for thought. But I would like to start by acknowledging the country that we are meeting on today. We are meeting on Aboriginal land, on the traditional lands of the Wamba people. And I would like to acknowledge the strengths and the resilience and the capacity of the Aboriginal people of this land. Also got some people here tonight who I'd like to acknowledge and welcome. So first of all, our board chair, Gail Murphy. Thank you very much, Gail, for the introduction. She does keep an eye on me, by the way. I do know she keeps a check on what time I'm sending emails and the like, so she is actually demonstrating good wellness in her staff. I'd also like to acknowledge the Mayor, Lindsay Renwick, from the Diniliquin Shire Council. Where are you, Lindsay? Are you there? There you are. Hello. Is Des with you? G'day. Des is the General Manager of the Diniliquin Shire, and many of you will know Des Bilsick well. We've also got tonight a whole range of our partners. I think we've got representatives from our Pink Ladies somewhere here tonight, have we? Where are you, good people? Volunteers from the Diniliquin Hospital? No. Oh, right, gone home now. Thank you, Pam. But we do have Interreach and Oka Medical Centre representatives somewhere. Welcome to you. And of course, we have our LHAC chairs and our members and our staff. A very warm welcome to you all, and it's fantastic to be here in Diniliquin. Now, is this person here with us tonight? She is. She's up the back eating a dinner. She's going to look up and get the shock of her life in a minute, Fiona. Have a look on the screen. I did something yesterday that I'm not in the habit of doing, and I will confess to it. Yesterday, I had an opportunity to visit the Junee jail with the Chief Executive from Justice Health. And we were actually running half an hour early when we got to Junee, so I said, oh, would you like to come and see one of our multi-purpose services? Because she actually hadn't been to one before. So poor old Fiona had two Chief Executives and a Director of Operations from Justice Health walk through the door and say, g'day, can you show us around? But the reason why I have this picture up is not because we did that to Fiona yesterday, and it's going to be part of my story. So thank you very much, Fiona, for helping me with my presentation tonight. And it must have been quite a shock for you. But it is my great pleasure to be a guest speaker here with you this evening. And you've probably noticed the colourful theme of our LHAC forum this year. So it's together in partnership, we share, we learn, we build and we grow. So I thought that I would use those themes to talk with you tonight. So have you seen signs around your facilities at the moment about our Your Say survey? Have you seen staff looking like Fiona? And could I say, you can't see it in the picture, but Fiona had hot pink earrings on and matching lipstick. She didn't even know I was coming. She was a perfect champion for your Say survey. But what is the Your Say survey for? We are currently running a staff engagement survey. So let's start with talking about our people tonight, because we have plenty of them, about 3,500 employees in Murrumbidgee Local Health District. That's a lot of people. But healthcare is actually a people business. And healthcare needs staff who are committed to their organisation, because they are more likely to bring their heart and soul to work with them every day. They're more likely to take initiatives at work, go the extra mile and collaborate effectively with the others. And there's actually an overwhelming body of evidence that engaged staff really do deliver better care. So I actually had a look at some research when I read that, because I thought, well, how does that work? So the King's Trust Fund are one of my favourite sources of information. The UK have developed or have divided up their health services into trusts, and their communities have a lot of say in how they run their trusts and their boards. And the King's Trust, I'm sure Jeff Pritchard will know of them, published a whole lot of really interesting information about clinical leadership and staff engagement. They published a lot of research to show that high levels of staff engagement lead to lower levels of patient mortality, make health services use their resources more efficiently, and deliver much stronger performance. And also engaged staff are much more likely to have the emotional resources to show empathy and compassion. And Gail will be going, aha, I know what Jill's talking about now. Despite the pressures that staff are under every day, if they actually are engaged, they're more likely to still deliver care with compassion, even though they're under pressure. So I hear you saying it's no surprise that truly engaged staff then deliver better care for patients. And so patients and staff go together to deliver the best outcomes for our people. And organisations who have truly engaged with their staff tend to have higher patient satisfaction. So with more patients reporting that they were treated with dignity and respect. So how do we know if we've got truly engaged staff? The King's Trust go on to actually say that the first step in engaging your staff is actually to have a very clear and shared strategic direction. So our Your Say survey that we're all doing now, all our staff, hopefully a good percentage of the 3,500 staff, is going to provide us with some incredibly valuable information. We did one 2 years ago as well. So the information that we get about how engaged our staff are will be some of the first steps that we will be taking in actually increasing patient-centred care and patient satisfaction, and will help us to understand those areas that we need to focus on to actually work with our staff to get them more engaged. So the King's Trust Fund go on to say that we need to have a clear vision that staff know and staff want to own, and it's got to be authentic, otherwise they won't really believe in it. So what's Murrumbidgee's vision? Is our vision something that our staff can connect with? And given that I know our board pondered over this long and hard, I actually do think Murrumbidgee has a vision that's right for our rural area. So our vision is that Murrumbidgee Local Health District will be a quality provider of rural health care, recognising the total health needs of individuals, patients and communities. And Gail, I do remember how long it took to write that vision, and we wrote it, I think, back when the organisation was formed, and I think we know a whole lot more now about how right we actually got that vision, because we used the words total health needs. We just weren't about providing hospital care. We were about looking at the whole needs of people, and we also included the word community. So I think we really do have a vision that our staff should be able to connect with. So what are the evidence around how our staff are connecting with our vision? Because I think it is a clear one. And I also think that we're starting to see some evidence that our staff are really, that vision is helping us bridge the gap between managers and clinicians. So for many years we've been hearing about the gap and divide against the clinicians who are working on the floor and the managers who are in the administrative offices. And there's a great analogy at Wagga because they call it the sixth floor, Dennis, people who are on the sixth floor. However, if we use the analogy of Wagga, I think Gail throughout the afternoon actually talked about an experience we went through last week. And it was, you know, something that Gail knew I was a little bit stressed about, just a little bit. But, you know, you got 6 experts who are independent coming down to have a look at the capacity of your organisation. and that they're actually talking to your staff, or our staff, about how effective is our governance, how effective is our leadership, how effective has that quality message got through to our staff about safety and quality, how good is our performance and our financial management, and so on. So we all did surveys, plus they picked randomly another 268, I think it was, people to survey, clinicians from the front line, and then they went and spoke to people. And so, we waited till the end of the day, and then we had a summation with them. And what they said to us actually was quite a surprise to me, and probably a great credit to many of the staff who are sitting here today. Our staff actually gave a lot of evidence back to those independent people who knew nothing about us, that message had got down. So what they said was that quality and safety and service improvement were at the forefront of what they did every day. It came from the front line, and the message came up from all the people they asked. We had told them the message, but often what the executive think is not what the clinicians will tell you, and there's a great divide. So I was really proud that day to hear that we are starting to make some traction on getting our messages right for our staff. So our executive leadership team have taken a pretty big challenge this year. We've developed some goals for ourselves, and they're different types of goals. You would think, chief executives, what are they all about? Budget, KPIs, on time, on budget. But we've actually set ourselves some different goals because we believe if we get these goals right, our finance and performance will follow in line with them. And one of my first goals is to increase levels of staff engagement. And I've just told you why. It's because we know that there is a direct link with lower patient mortality and better patient experience. We've also got a lot of goals, but some of the most important ones to me are reducing the incidence of falls in our facilities, medication errors, hospital-acquired infections, and I've also got a goal to increase the community awareness of our LHACs. So through our quality improvement standards, our staff are starting to develop some really good patient advocacy skills. I'm going to tell you a story now, though, where we don't always get it right. And our executive are using patient stories as an opportunity for lessons learnt. And one of the things they found out about me, I probably haven't told Gail this, is that when I hear a really sad patient story, I actually tend to get a bit emotional, and I can see Dennis smiling because sometimes I get so emotional I can't speak. But I think it's very good for executives to learn from patient stories and keep ourselves connected with what we're doing. It's very easy when you're in management just to focus on the dollars and the numbers and the data, but unless you actually engage yourself with people, then you lose your direction. And then that message filters down to the staff. So I'm going to tell you the story now of John. John was a patient who suffered, and these are real stories from our people. John is a patient who suffered some really severe burns in an accident on his farm, and he was airlifted to Concord Hospital in the burns unit, and he was there for quite some months. This is not John. I've just got a series of patients. Clearly it's not John because it's a woman. So those sections got a photo library. These are our real patients and real staff that you'll see me flicking through tonight. So anyway, John, after many months, was released back, and he came from a very small village in our local health district. After a while being at home, he got quite concerned about one of the grafts on his ear, and so he presented to a local emergency department. He actually had a care plan that had been developed for him at Concord, and in the care plan there are a whole bunch of things to do if his grafts weren't healing. And the message in his care plan said that his local emergency department could link him with his specialist at Concord. So following his care plan, that's duly what he asked. Unfortunately, though, when he presented to our emergency department, our staff were unclear about how to link him in with a specialist in Concord. So he then contacted his local medical centre with the same request. And the medical centre staff were also unsure about how to link him in with his specialist at Concord. So he went back to his health facility because by now he was getting worried. And the Murrumbidgee health professional this time actually sought advice around how to link John with his specialist at Concord. And that was quite a difficult journey for that person, because not only did she have to organise the appointment with Concord and get the specialist on the line, but she actually had to work out how to do it. Because we've got the technology, but we haven't yet got the maturity about using it to our best advantage. So John finally was given contact with his specialist, and the appropriate treatment was organised. And there was a message in that story in that sometimes we think that people have got a clear pathway for follow-up care. But it's really easy if things are hard or a bit different. In that case, it was pretty different because it was only a small hospital, and the thought of linking up with Concord was probably quite terrifying to that staff member. But fortunately, we've learnt from the story of John, and we are now really working very hard around all the processes that we need to put in place for our staff to understand how to use our telehealth technology. Because unless they use it every day, it's actually quite difficult. So patient stories provide us with very valuable feedback on how we can improve our care. Am I on the right one? So we often talk about patient-centred care or person-centred care, but what is it really? So my second story tonight is a bit of a personal story because it's actually about my dad. Now, I think when Tony was talking tonight, I mentioned my dad. So for those of you who've forgotten, he's 87 and he still lives at home with my mum in Tumut. And I actually used this patient story for Rosie's accreditation, spontaneously, Rosie, your area, the border region, when we had our national standards. And I had to do an introduction, I think, to the National Standards Survey team, and this story popped into my head, and I used it as an example about how we provide patient-centred care. So I thought I'd repeat it tonight because it is a personal one. My dad, at 87, stopped working when he was 80, and he was a scientist. He's a person who's a little bit like me. He's very extroverted, can't stand being at home, and goes into town every single day. People in town know him because on a Monday he does Tai Chi, on a Tuesday he goes walking, on Wednesday he goes to men's group, etc., etc. Every single day he's got something, and on a Saturday he goes to the men's shed. So anyway, on the day after his gentle exercise group, coming out of the butcher shop, he fell in the gutter. And he dusted himself off, somebody helped him, and he drove himself to his GP. He had a bit of a skin tear on his leg, and he went up to the hospital and they x-rayed him and they dusted him off, and he had a very bruised confidence. He was quite shaky. So anyway, they sent the community nurse. So I got a phone call from my mum saying the community nurse was coming to see Dad. And to be honest with you, I actually got a bit worried, because those of you who know me know that I used to work in the community sector, and I thought, okay, what are they going to do? I thought, oh, okay, they'll probably drop in and do his wound every couple of days. They'll probably offer some home assistance, maybe Meals on Wheels or something like that to help out, because Mum's getting a bit tired and frazzled by this stage. And they might even offer respite care, and I started to get quite anxious because I knew that if my dad's independence was cut off, that he would be very unhappy. So Lorraine O'Sullivan, where are you? You should hold your head very high, because the nurse who visited my dad sat down around the table with my mum and my dad and a cup of tea and asked them what were their goals. And my mum said, "Oh, it has to be Colin's independence. He'll drive me mad if he's here all day, every day. And I do all the cooking, so I need Colin to be able to go into town and do the shopping, because I don't do shopping," she said. And Dad said he needed to keep going to his community groups. So that community nurse, instead of going for the traditional wound dressing, checking the blood pressure, because that was the other thing, he's had low blood pressure, so I thought, oh, they'll be coming in, checking his blood pressure, doing his wound. No, they didn't. You know what they did? They organised him a disability sticker for his car so that he could park closer to the shops and the places where he was going. They organised an occupational therapist to review his walking, and guess what? He didn't have a stick, so then he got a stick, a walking stick. And they rang the GP and said, could they keep an eye on his wound on his leg? And he's fully recovered, still going into town every day and driving everybody mad, but he's fully independent and he's still at home. And I just think that was a fantastic story, Lorraine, because what those nurses did was they treated him with dignity and respect, and they actually found out what mattered to that family. They didn't just go in and treat the wound or treat the blood pressure. They actually found out what their beliefs were and tailored the care to actually keep him independent. So it's a beautiful story, and it's true. So in our local health district, we're actually learning to focus on patient outcomes rather than just treating the disease. And it's very easy as clinicians just to treat a disease. It's what we know. We can do it in our sleep. I heard a midwife actually telling a story in the forum next door today. For those of you who don't know, there was another health forum going on next door where we had all of our child and family health nurses and a whole lot of partners from the Aboriginal sector and education and NGOs, and we were all there learning about how to build stronger support for Aboriginal women and families, particularly with young children. And one of the midwives got up and gave a story, and her story, the message in there was to sit on your hands, keep quiet and listen. It was a really interesting story because she said, once again, they go in and they just focus on ticking the boxes, weighing the baby and doing everything. But for Aboriginal women, it's not about that, it's about listening to them. So in our district at the moment, we're very much focused on patient outcomes rather than ticking boxes. Firstly, that patients and carers are given the right opportunities and the right information and support, and that they take an active role in the decisions about their care and treatment. And secondly, we have to involve carers and patients and communities in how we plan our services as well. And finally, our healthcare professionals, we actually need to work on their attitudes, skills and behaviours, because we can influence those through training, and we need to monitor them. Because even though healthcare professionals get out of bed every day to do a good job, sometimes if you do the same work over and over again, you can lose your compassion, and we have to keep working on staff to ensure that they keep that. So services can better reflect the needs of patients if they're meaningfully involved. And so patient-centred care actually starts with our staff being engaged and compassionate. So that takes you back to Fiona's picture about how she is actively working to get her staff engaged. So that's really good. That's why I was so happy when I saw you yesterday, Fiona. The second part that I'm going to talk about is together in partnership we share. So I've just talked about sharing with patients and carers to deliver better services. But we also share patient care with a whole range of organisations these days. And I was thinking tonight as I was getting ready, about 10 years ago when I used to be a community nurse and midwife and child and family health nurse working with high needs women and families. And I can remember when I first started as a manager in community health, I remember a senior executive telling me, Jill, We do acute care, we don't do primary health. And I thought about that tonight. It just came back to me, and I thought about how things have changed. Because in a rural health service, we can't silo ourselves off just to do that portion of care and think that somebody else is going to do that bit. Because we all know that primary health care is 70% of the care people receive. It's the care they receive from their GP, etc. So we can't just say we're going to do that much. We actually all have to play in the space of health together. Otherwise, people get a very fragmented experience. So we actually work with a whole range of partners now. Things are very different than they were 10 years ago, where I wasn't even allowed to talk to the Division of General Practice about GP vacancies. So our partners now include many, many people. The list is long. But we are working side by side with the Medicare locals and the soon-to-be primary health networks. They're very, very important to us because in a rural health district, we're actually default providers of primary care. If a GP finishes at 5, who provides that GP care after hours? Our hospitals. And in towns, when the GPs need time off, when they've had that hard-earned break, our emergency department becomes a GP clinic. So we have to play in the GP space and we have to work together. And we've got many other partners these days as well. We've got voluntary organisations, NGOs. We have joint executive meetings with family and community services where we're talking about our vulnerable children. You've just heard about Justice Health, Forensic Mental Health. All sorts of agencies are now our partners. But what happens when we don't share care? And this is the true story just from yesterday when I visited the Goulburn, not the Goulburn jail. Oh, I didn't go to Goulburn. I went to Junee, as you saw with Fiona. So at the Junee jail, I heard a story directly from a patient. So after we had spent a very long period of time being screened and scanned within an inch of our lives, 20 minutes later, I set foot inside the jail. And we had a really interesting discussion with the general manager of the jail and found out they had 820 prisoners or people in custodial care and 300 staff. Behind those walls are a lot of people. We found out that 80% of them came into custodial care with a substance addiction and involuntarily had to go through detoxification. And we had a long talk about how healthcare is provided in custodial environment, and then I got to go into the health clinic with the patients. And it was such an eye-opening experience. Well, by the time we got to the executive meeting, my brain was just exploding about what a different world it is inside a jail. I got to talk to a man, and his story, he and the nurse told me his story, was really quite confronting. I'm going to share it with you because it is also about one of our facilities. So Alex is a 75-year-old man, and he was in the health clinic because he had a high level of anxiety. He was finding it difficult to settle into the custodial setting. He'd never been in jail before, and he had very high blood pressure. He's extremely anxious. So his nurse was talking to him and asked him some questions, and I listened. His story was that his wife is an aged care resident in one of our residential aged care facilities. And he lost his licence because he failed his driving test. So he couldn't go and see his wife. So what did he do? He got in the car and he drove without his licence to see his wife. He got picked up by the police, got charged. They let him go. So over the next week, he got more and more anxious. and more desperate. So he started drinking. And then he got back in his car after he'd been drinking and self-medicating and drove back to the residential aged care facility. He got picked up, he got charged, and that's how he ended up in Junee jail. So I ask yourself, if we'd done care better for that person, if we'd shared care and support for that man, is jail the right place for him? And it really was a very, very powerful story, and actually the team came back and shared it with my executive team, and it really opened our eyes up. So I've got a happy story now about shared care. Is anybody here from Finley? Hello, Kylie. Okay, here's a lovely story about sharing care. So if I get it wrong, Kylie, you'll have to jump up and correct me. Okie dokie. So one of my favourite and recent examples, Gail and I, off on our site visits as we do, and we found this beautiful example about working in partnership. I didn't really know about how good it was. I'd heard Rosie talk about it, but I didn't really know until I saw it. So, and it involves the LHAC as well. And so there was a long-standing physiotherapy vacancy in Finley, many, many years, I think. Kylie and Rosie had been desperately trying to recruit to the position. The LHAC kept talking to the health service and telling them about their concerns, about the community members were raising about lack of access to physiotherapy services, which, as you all know, are absolutely vital in any sort of rehabilitation care, and anybody with a chronic disease really often needs physiotherapy assistance and support. So this is a really great story about sharing resources, because at that time the Hume Medicare Local had just completed their comprehensive needs analysis, exploring where there were gaps in the community. And so the stars and the planets converged, and the gap analysis clearly showed the need for this service in the town. So together, us with the Hume Medicare Local were able to pool our resources, and a partnership was born. Through the consortium, we engaged this wonderful group called Back on Track Physiotherapy, and that's Jeremy right there. Where's my red button? There's Jeremy. And Jeremy actually also employs some allied health assistants, which is fantastic. And they are now providing a public-private service to the residents in that town, to our patients in our facility, to community health patients, also to private patients. And it's been such a success in that town. Rosie, I think it's gone to other places now as well, hasn't it? Because we've been able to use that model. So even though we thought we can't solve this problem, by sharing the problem, sharing the resources, finding a solution, Jeremy's the happiest person in the world there. You can see by his face he's a happy man. And it just shows a really great example of how we can actually do care better if we try different things. So I'm going to talk about Together in Partnership We Build, because one way for us to make partnerships more successful is actually about looking at things differently and looking at the outcomes. We need to be outcome focused and to define the purpose and the added value of partnerships right from the outset, because partnerships can actually sometimes be quite difficult and difficult to manage, particularly if you've got a number of players around the table. And we've got some consortiums now where we've got 4 or 5 players all sitting around the table. Nobody's the boss. So you've got to all have that really clear vision about where you're going, because if you don't have it, you're just going to argue all the time. So the true value in partnerships is really through those shared objectives. And Kate, who has given up her beautiful hot dinner to sit there and play this video for us, might be able to go back to her dinner. We're going to hear a story now through animation, and this is called Sam's Story, and I apologise, there might be a couple of you in the room who've seen it. So when we're talking about partnerships, you start to hear the word integrated care come into the conversation. So the jargon of integrated care is much used in health circles, but what is it? What does it mean for patients? So I think this short animation will bring integrated care to life for you, and we'll now listen to Sam's story and hope the technology works. Miss Kate. It's one from the King's Fund. Can we turn it up?
Over the next 20 years, the number of over 85s in the UK will more than double, meaning many more of us with multiple long-term health conditions. Our current health and social care system won't cope. Fundamentally, it's the same system as when the NHS was set up, designed to treat episodes of illness one at a time. Already, we're failing to give vulnerable people the care they need, and we're set to run out of money fast. Meet Sam. He's 87 and suffers from emphysema, a disease that makes it hard to breathe, and also has type 2 diabetes and arthritis. Sam was coping pretty well until his wife passed away, but is now lonely and increasingly depressed. Sam frequently visits his GP, but finds it difficult to discuss all his needs in a brief consultation. If Sam can't get hold of his GP in a crisis, he calls for an ambulance. Each time, Sam spends time in A&E, and is often transferred to a ward as well. He sees lots of different healthcare professionals and has to explain his conditions repeatedly. Frustrating. And Sam often has to wait to be assessed by social services before he can go home. The result? A lot of unnecessary time in hospital. And when he gets home, a lack of coordination between his GP and social care often means he doesn't get the support he needs. Eventually, after several hospital visits in just 6 months, it's decided to admit Sam to a care home. But what if Sam's health and social care services were more joined up? Let's imagine one of Sam's carers is given overall responsibility for coordinating his care. For example, Kathy, a district nurse. Kathy meets with Sam, his GP and his social worker. Sam explains that he wants to manage his conditions at home, and together they design a care plan which they can all access online anytime. Sam now gets more visits from Kathy at home, which helps him manage his emphysema and diabetes. On the occasions when he does have a crisis, Sam calls Kathy rather than an ambulance, so goes to hospital less frequently. And even when he is admitted, he's discharged after a quick review of his care plan rather than having to be reassessed. In this scenario, Sam's health and social care is funded from a joint budget, so the team can make smart decisions about how it's spent and call on the help of other social services. For example, as his condition deteriorates, the team decide to fit a seat in Sam's shower, provide him with an oxygen cylinder to ease his breathing, as well as a medication dispenser with a voice prompt to remind him to take his pills. Kathy talks to Sam about his loneliness, and he agrees to weekly trips to the shops with a volunteer from a local befriending charity. So now, Sam doesn't have to be admitted to a care home, instead getting the help he needs in his home. He feels happier, is healthier, and better use has been made of resources within the system. Let's recap on what transformed Sam's care. Put simply, local leaders in the NHS, social services and the voluntary sector created a shared vision of what good integrated care looked like, centred around the needs of people like Sam and their carers. They pooled resources across health and social care, built multi-professional teams and created systems to allow Sam's information to be easily shared. Sound idealistic? Well, this is actually already happening in a few places. Now it's time to make sure it happens everywhere. Let's reimagine how we provide care. Get inspired at kingsfund.org.uk/joinedupcare.
So, Sam's story provided us with a lot of food for thought, and I'm really pleased to say that, like the UK, we've now started on the journey around what our Minister for Health calls truly integrated care, because integrated care isn't new. It's been around for years, but it's actually quite difficult to achieve. So Murrumbidgee Local Health District actually put in for some additional funding recently, and we have been successful in a model of care that we're rolling out now, and we're trialling and starting in, funnily enough, Temora and Wagga. And we've got 5 partners in our model. It is called CHESS, which is Chronic Complex Healthcare Engaged with Stakeholders and Services. So our partners are the Medicare Local, New South Wales Ambulance, Baptist Care and Home Care. One of the most exciting things that we're working on at the moment with the ambulance is, and it's already had a proof of concept, is an alternative destination. So how it works is patients who have got chronic disease, who have got particular risks, are identified as being suitable for this model. The thing about this model is it's entirely GP focused. When we actually analysed the data to put in our submission, we found a whole lot of patients who were bouncing around in the hospital specialist system. They would be in Dennis's hospital, a lot of them, and also in Griffith, and they were there with chronic disease such as chronic obstructive pulmonary disease, highest in numbers, chronic heart failure, and they would get really, really sick, end up in hospital for quite some time, deteriorate while they were there, have a long period of care, and then they'd be discharged back home. And then when they started to get sick again, they'd go back to the ED and they'd end up back in hospital again. We did a whole lot of patient stories when we were doing the submission that clearly demonstrated what the data had told us. We just went and spoke to some of the people in your ward, Dennis, who are frequent flyers, we call them. What was missing from their care was the GP. The GP for people with chronic disease has to be firmly in the centre of the care for those people, and the whole aim is to avoid them being in hospital. So what we're focusing on not at that pointy end when people are really sick in Wagga Hospital, Denny Hospital or any of the hospitals, is actually identifying those patients through a risk stratification process when they're in the GP books early in their disease process, and then with the GP getting a good care plan and wrapping all those services around them. And when they get sick, if we haven't got them to the pointy end, the ambulance have worked on us and have agreed that instead of taking them to the ED, if they actually assess them and talk with the GP, they'll take them to the GP or somewhere else that's agreed rather than to hospital. So it all depends on the patient and it all depends on the care plan. But we've already trialled this alternative destination with New South Wales Ambulance in other parts of New South Wales, and it's working really well. So we're starting on a whole lot of new models of care. So we need to work with a whole range of our partners to deliver truly integrated care, and we're well advanced in that journey. So together in partnership, we need to also build health literacy. I thought I'd better put this one in because it's something that we can work on with our local advisory committees. And health literacy in some instances starts with our patients just understanding health messages better from GPs, clinicians and care providers, and also for them having information such as brochures and websites that they can clearly understand. So we thought that a simple initiative that LHACs might want to consider is Ask Me 3, and on your table is a little form. And I think it's a great message for LHACs to consider going out there to their communities and actually saying it's okay to ask questions when you go to visit your clinician, your GP in particular, to help you better understand your health condition. And on the back, there are 3 prompts for people. What is my main problem? What do I need to do? And why is this important for me? We got a couple of stories actually from patients, and they're just very simple stories, but it just highlights how easy it is for people to get the wrong information. So there was a man told us that his GP was taking his history when he went the first time, taking his long history, and he asked him if he had hypertension. He said no. And then later on he was examining him, he was putting the blood pressure cuff on, and he said, "Oh, doc, I've got high blood pressure." It's just a really simple example of how people don't know or may not know that hypertension is high blood pressure. We really need to think about the language that we use with people. There was a lady that I was talking to once in hospital only a couple of weeks ago who was there because she took all her pills in one go instead of at the intervals throughout the day because she didn't understand the instructions that had been given to her. And a story actually that Sechin gave me was a man was given drops for an ear infection, and they were oral drops, and he didn't know the difference between oral and oral, and he put his eardrops in his mouth and wondered why his ear infection wasn't getting better. So some of the messages are very simple, but it's easy to get them wrong, and to think that taking all your medication in the morning instead of 3 times a day can land you in hospital is pretty powerful stuff. So that's the Ask Me 3 that's on your table, so LHACs can consider doing that. Finally, just the last section is in partnership we grow. And some of these slides are very recent. This one was it Monday, Gar? Gosh, the days have merged together very quickly. The last couple of slides I've got tonight are actually about growing the health service and about growing our capacity and growing our leadership. So Gail and I had a very lovely job to do on Monday. We have the Don Kendall Memorial Award for Leadership, which was a wonderful man, Don Kendall, who started off the Rex airline, who is a well-known aviator. Started this leadership award for his and it was about pioneering spirit. And so it has continued on in our health district every year. There's a beautiful red gum base with a very large, heavy eagle on top, which is the trophy. And every year we go out and call for submissions about our leaders. There's quite a few leaders sitting in the room here tonight amongst you who have won this award in previous years. We had a beautiful ceremony on Monday for our winner this year, Kath Hanrahan, who actually gave me an idea for this segment, because she is a homegrown leader that we have grown ourselves. She started her career as a new graduate in a medical ward, actually at Wagga. And she has worked her way up over the years. She's still a young woman. She's got one little boy. Where is she? You can see her there. She looks quite overwhelmed. And there's Gail looking proud, her husband holding the trophy, and Dr. Ty, who's the nephrologist, who's really proud of her. And this is Sharon Celtica, who was actually the Don Kendall Award winner last year, another beautiful, caring nurse. But Kath's story was actually how we've grown a leader, because she started off as a new graduate. She worked her way up to being a ward nurse. She worked her way up to being a clinical nurse educator, and she eventually took the reins as the nurse unit manager in the renal unit at Wagga. And the story that her staff wrote about her in her submission was just beautiful, and they talked about her concern for the welfare of her patients and families were always paramount, that she is a fantastic role model who leads by example and does not demand more of her staff than she delivers herself. So she's been commended as her role in leading the renal service. You saw in Dennis's slides that they've just opened a beautiful new service there that's been expanded, and she's always kept her compassion all the way through. She's enhanced staff morale, and there again is the link between staff morale and improved the patient outcomes in the renal unit. She's got patients started on home dialysis, and she's introduced a whole lot of new work skills. She is an exemplar example of growing our own. And speaking of exemplar examples, Lorraine O'Sullivan, this is a slightly different example. Where are you? You better come over, because she's got to tell part of my story, because I can't tell it as good as Lorraine. So some of you will know by now that I call Tumut home, and you may have worked out too that I'm also a midwife. So I can't actually deliver this address tonight without mentioning those two things just one more time. So you can see there a photo of the midwives from the Festival of Falling Leaf, not this year but last year. But the reason why I love this photo is because our nurses and our midwives, it symbolises where we've been and where we're going. So Lorraine's maternity service at Tumut identified a big issue a while back. That was that the midwives are all getting old, they're about to retire and they weren't going to have midwives. And oh dear. So being a very good health service manager and a good leader, they did something about it. They didn't wait, they just got on with it. They got 3 midwives, they got 3 staff who wanted to train as midwives, and they went off and did their training. And I bet when they did their training, they didn't think they'd be marching down the main street of Tumut in some matron's outfit when they signed up to be a midwife. But they now have trained, and they feel that interaction that they've had with women and their families and the professionals and clinicians that they learnt from have given them a whole new life experience. And Lorraine has got a couple of quite funny stories that I just could not pull off about their work training as midwives in Tumut.
Well, I think the section that rang me and said, have you got some funny stories you could tell about the midwives in Tumut? So I put it out to midwives, what interesting things have happened while you were doing your training. And because we've got a diverse group of midwives, we've got people like dinosaurs like myself that have trained many years ago, and then we've got really young midwives who've only just finished their training. I got quite a few interesting responses to that. One of the midwives that recently trained said to me wide-eyed, I can remember when this lady turned up at our maternity unit and said, the doctor has sent me up for a seduction. I don't know what a seduction is. Well, obviously, for those in the room that don't know, an induction is when they induce the labour. But this lady thought it was a seduction, probably very similar to what the high blood pressure and the hypertension is about. And that got the midwives going. There was another midwife that said, yeah, remember the time in the car park when the husband came racing into the hospital and said, my wife's out in the car park in the car, she's about ready to have the baby. And by the time the midwife ran out there to the car park to assist, she saw the poor lady trying to climb over from the back seat into the front seat because the child lock was on and she couldn't get out of the car. Another one had the actual lady made it into our labour ward, and of course she was 10 centimetres dilated, so there was no turning back. She was going to have that baby there and then. By the time the midwife had the delivery and congratulated the mother and put the baby on the chest and congratulated the father, she turned around to the door and there were 3 wide-eyed children staring, and she looked at the mother and the father and said, and they said, don't worry, that's the quietest they've been for years. And there's one final one that the nurse manager of maternity told me in her time when she was doing her training, she was learning new skills. And one of the skills was she had to learn to examine a woman. So she examined this lady to see how far dilated she was, and she jumped back from the lady, stared at the tutor and said, something just grabbed onto my hand. And the tutor said, well, I'll just check what your dilatation is. And when she finished the examination, she turned to the student midwife and said, that's the baby's hand, and there is no way that baby's going to be born that way. And the midwife said, well, how's it going to get out then? And that's when she first learnt about caesarean sections. So that's probably the stories that I've got to tell you about the midwives at Tumut.
That's all part of the fun of growing our own. Thank you, Lorraine. I knew when I heard those stories that I couldn't deliver them as well as Lorraine could have. Yeah. Okay, this is my final slide, so hopefully you've got your desserts in front of you now. So, look, in summary, I've spoken with you this evening about partnership, about how we share and we learn and we grow. And just to let you know one final thing, it's actually a big journey that we're on, and so we've recently launched our People, Our Future. And Our People, Our Future, and Sechen's done that beautiful logo because you know she's so talented. It's just another thing she's done, is actually our culture change program. And this is where we need to tie all of the threads together. Because we actually need to make sure that we have got engaged staff, because that's how we're going to enhance our performance and create and sustain a whole culture of excellence. And so we've defined where we want to go in our culture of excellence as an environment where employees feel valued, where clinicians see patients are receiving great care and patients see the service and the quality of care that they get as extraordinary. So tonight we've heard about patient-centred care starts with staff being engaged and compassionate. And you've heard how we're actually doing a survey to measure our staff engagement levels and how we're using experiences and partnerships to grow better care for people. We need to work with a wide range of partners to truly deliver integrated care. It sounds easy in Sam's story, but it's actually really difficult to achieve. And you've heard also tonight about how Murrumbidgee is growing new models of care and a new dynamic and flexible workforce. So thank you all very much. I would just like to acknowledge our sponsors. I better get the list here. RSL Deniliquin, could I just say, this is the most fantastic venue and they have been so helpful to us, and I really am very grateful for them. And they've also contributed, I think, Pam, towards our forum, so we'll be writing them a really big thank you. Regional Express Airlines and the Loddon Mallee Murray Medicare Local, Murray Shire Council and Rich Designs. Thank you very much.